Now, many of you have gone through lab and will have a lot of this as background info, and the animation that you saw for breathing, the mechanics of breathing. Try to apply that to our discussion today, but we are going to focus on details, innervation, some origin insertion, arterial supply. And they'll be used in the context of breathing, but we're not discussing at length how breathing works, how air is moved, how the diaphragm contracts. Actually, we're not talking about the diaphragm very much at all, because I know you did that in detail in lab, or will tonight. So let's finish our discussion of the bones. The thorax is the entire chest, and the bones that comprise the thorax are the sternum in the front, the ribs laterally, and the bodies of the vertebrae posteriorly. That makes the thoracic cage, or the thoracic cavity. The costal cartilages are also part of that cage. They connect the ribs to the sternum. And we'll talk about those a bit more in detail as we look at articulations and the muscles associated with the ribs moving forward. So we introduced that last class, and now we're going to look at the ingredients, the building blocks of the thoracic cage, the thorax. So the sternum, or the breastbone, is really three parts, or has three parts to it. The manubrium on top, the larger rectangular body in the middle, and the xiphoid process at the bottom. The xiphoid process at the bottom. And it's actually quite easy to manipulate all of these aspects of the sternum. They're very superficial. There's a few layers of fascia and skin between you and the sternum, but you can fairly easily, well, I shouldn't have worn a tie today. You can fairly easily manipulate the manubrium at the top. You can feel the angle, the point where the manubrium meets the sternum. There's a little bit of an inflection and a line. And then the xiphoid process, dead easy, right? It's hard to feel the actual process, but the point where the ribs meet is at the xiphoid process. So if you can feel the costal cartilages as they come up and converge, that point where they converge is the xiphoid process. And that is the go-to landmark for wearing heart rate monitors when you get to XPhys. Xiphoid process. You want them right at that level. So excellent landmark for that. We've talked about this, of course. The sternum articulates with the clavicles and the costal cartilages. The clavicles, you can see the articulation points here at the clavicular notches at the superior surface on the lateral edges of the manubrium. And you would have felt them when we were palpating that sternoclavicular joint in lab earlier this week or late last week. You can feel there's a little bit of a divot and a raised bone portion that's actually part of the clavicle, and in that little depression is the clavicular notch. And then you can lift your arm and shoulder and feel that joint move around. It's articulating at the clavicular notch. And just medial to that, not that it serves much purpose, but is obvious to palpate, the suprasternal notch. Little saddle right in the middle of the manubrium. And I didn't highlight it, but the sternal angle, if you feel a little bit lower, there's a point where the breastbone feels like it inflects, it bends, and that's the sternal angle. It is harder to palpate the points of connection for the ribs along the body. There's a lot of muscle there, some more so than others, tissue, fat, skin. But we can imagine what it would look like using our diagram of the thorax. We know there are 12 pairs of ribs. We didn't know that before. We know that now. And the ribs are the structural support that encase the thorax. They encase and make up the sides of the thorax and provide points of attachment for many different muscles and passageway for veins, arteries, and nerves. We'll talk about it shortly. Now, dimensions will change with everyone, but a few general characteristics hold true. The 7th is the largest or longest rib, and they get progressively smaller as you move away from the 7th rib. The 1st and 2nd, all the way at the top, are generally very short and flat and beefy, very thick. But the rest of the ribs are all varying degrees of length, the 7th being the longest. 7th is also the border of the true ribs, what we call the true ribs, or the vertebrosternal ribs, which simply indicates that they connect directly from the vertebrae to the sternum via their costal cartilages. So our true ribs have direct connections between the vertebrae and the sternum. And you can see them highlighted here. Direct connections. These differ from ribs 8 to 12, which do not have direct connections. They're still ribs. Most of them still have costal cartilages. But those that do not connect directly to the sternum. They connect to superior cartilages. They're vertebrochondral ribs. And you can see that on the infero-medial border of the rib cage here. These costal cartilages sort of cascade. Ribs 10, 9, and 8. They all tend to meet and then insert on the costal cartilage of the 7th rib. They don't attach directly to the sternum. So a small difference in classification, and then it's hard to see ribs 11 and 12, but they don't have costal cartilages at all. In fact, they don't even look like normal ribs. These are floating ribs, or vertebral ribs. They're not vertebrochondral, they're not vertebrosternal, they don't connect to the cartilage or the sternum, they don't connect to anything except the vertebrae. You can see 11 and 12 hanging off the thoracic vertebrae 11 and 12 at the back, the posterior portion of the thoracic cage, with no connections, no costal cartilages on their distal ends. Now, an easy way to remember rib number and its articulation with the vertebrae is that ribs articulate with the same numbered vertebrae. The same numbered vertebrae, either directly or on the superior portion of the same numbered vertebrae. So rib 9 articulates with thoracic vertebrae number 9, or vertebra number 9. Rib 3 articulates with thoracic vertebra number 3 at the superior border, and I'll show you that in a second in a bit more detail. We can't see that very well with this anterior view on the screen right now. So we're going to take a little time to explore these articulations. We've talked about the idea that ribs articulate, where they articulate. You know there are superior and inferior facets on the head of the ribs that match up with the demifacets on the vertebrae. And there are also facets on the tuberosities that articulate with the transverse processes of the rib. So I just want to show you that in a bit more detail. We can look at the head of the ribs, the neck of the ribs, and the different features, and then we'll look at how they articulate. So let's take an example, this rib, the 8th rib. And a few landmarks of the 8th rib. So we know, I don't like that one. Let's do the 7th. There is the head of the 8th rib. Right. Where am I going? There we go. Head of the 7th rib in this case, containing both of the articulating surfaces. Neck of the 7th rib at the level of the tuberosity. And then the body, by far and away, the majority of the rib is the body. And you can notice the shape gradually moves from a rounder column at the neck to a flat, bent surface as it moves around the thoracic cage. And that occurs at the angle of the rib. That point, that transition point where you move from that rounded bone shape to the flattened surface of the rib, and the rib starts to curve in more, is the angle of the rib. And that's usually pretty well defined and easy to observe on an individual bone. Also notice what's called the costal groove. So it's on the underside of the rib, here highlighted in green. And it's sort of easy to see, but it looks like there's a little hollow on the inner surface running around the length of the rib. And this is important because that's where the vein and artery and nerve travel. And there's one for every rib, for every space between the ribs. And so this costal groove is where that structure, those three items, will move around the thoracic cage. We'll see that coming up. So knowing that we have the superior and inferior articulating surfaces, and then one on the tubercle, if we zoom in and look at how the rib meets the vertebral column, it starts to make a lot of sense. We can see that articular surface here on the tubercle of the rib, matching up with the transverse process of the vertebra. And then let's see if I can do this without it being too confusing. See the head of the rib? The articulating surfaces meeting with the inferior demifacet and the superior demifacet on the vertebrae. If this is the 7th rib, it connects superiorly with the 7th vertebra, right? Same numbered ribs and vertebrae. If I move inferior, because as an example, the inferior ribs connect directly to the vertebrae. Here, the 11th rib articulates with the 11th vertebra. And all of the ribs have these connections. So we should be pretty well versed in the articulations and in identifying the vertebrae. Without clicking on one of these, you could tell me this is thoracic, right? Giraffe's head. That's obvious. Compared to the moose head of the lumbar vertebrae down below. And other defining characteristics, but none that are as fun as those. Okay. So we got costal groove, we got the costal angle. You might have been following along with these diagrams that I included in the slide set, but everything that I was showing you in the app is the same as what's shown here. I just haven't highlighted them. And that's it for the structure of the thorax. Let's talk now about muscles of the thorax, and specifically muscles of the vertebral column. Then we'll move anteriorly and talk about muscles of the ribs themselves, and then of the abdominal wall that support and help flex the vertebral column. It's all with respect or in the context of the vertebral column. And there are a lot of different candidate muscles that we can talk about. So there could be a lot of information to memorize. Muscle names, origins, insertions, positions, innervations, blood supply, venous drainage. But we're not going through all of these in depth. I think some of you even just got overwhelmed hearing that list. We are focusing, at least in the posterior compartment, on the Erector Spinae muscles. Muscles that keep the spine erect. The Erector Spinae muscles. They are iliocostalis, longissimus, and spinalis. Moving from lateral to medial, outside to inside. Iliocostalis, longissimus, spinalis. ILS. I like standing. Erector Spinae muscles keep the spine straight. I like standing. Iliocostalis, longissimus, spinalis. So you've got the names and the order. No studying needed. Iliocostalis, let's take a look. Each of these are divided into different regions depending on what portion of the vertebral column they span, where they originate and where they insert. And we're not focusing so much on the divisions as much as the muscle as a whole, or all three groups together. So there are divisions. You can see thoracis, indicating this is part of iliocostalis that covers the thoracic spine, or lumborum, part of iliocostalis that covers the lumbar spine. But we're considering these groupings together. Same thing with longissimus, thoracis, and cervicis, that covers the cervical spine. And then most medial, I like standing, S, spinalis, which you see shown here in green. Spinalis largely only the thoracic portion, but there is a cervical portion as well that's smaller. Now I want to tell you about the innervation and blood supply. And I think I'll just show you first so that you can write it down. I'll put it on screen so you can write it, and then we'll explore what it looks like with the app. But I wonder, innervation of the deep back muscles, nervous supply of the deep back muscles. We've actually talked about this already. Does anyone want to take a stab, a guess, at what nerves might innervate these deep back muscles? Anybody remember way back when we talked about the nervous system, the brain, the spinal cord? Matt, you want to give it a go? Brachial plexus is a good guess. It's not correct. It is a good guess because it's in the same area. Brachial plexus is something we'll come back to a lot in the upper limb. Brachial plexus is exclusively upper limb. So we'll get back to the brachial plexus and see our familiar nerves and listen to the song maybe again. If we get through enough, I got another song for you, which is going to be fun. I'm actually in this one, but not today. So not the brachial plexus. What else did we talk about? And this was sort of in passing, so I'll forgive you for not remembering. But does anyone remember? We made a special point to talk about it. No? Remember the, are you going to raise your hand? That was an adjustment. Okay. Dangerous to do an adjustment like that when I'm asking a question. Remember the spinal nerves, as they come out of the vertebral column, they split into what? Rami. Posterior rami exclusively innervate the deep back muscles. And I'm saying posterior rami of the thoracic spinal nerves here if the muscle in question covers the thoracic spine. It could be posterior rami of the cervical spinal nerves or the lumbar spinal nerves. It depends what region of the vertebral column we're in. But posterior rami innervate all of these. There are smaller branches that go off to each muscle, but for our purposes, posterior rami innervate all of these. So we're starting you off easy with origin, insertion, innervation, supply. You're going to have tables where you write a muscle down and write down origin, insertion, innervation, supply. Same innervation for all of these. It won't be the case moving forward. We haven't talked about arterial supply, so I'm just going to tell you. These are lumbar and intercostal arteries. And you'll notice moving forward, whenever I write N period or A period, V period, that means artery, nerve, vein. That's just the subscript instead of typing it all the way up. So let's take a look. You had a chance to write these down. Let's actually see what it looks like to be a posterior ramus or an intercostal artery. So, Erector, Spinae. These are the Erector Spinae muscles. Okay? You can see them on both sides. From outside to in, from lateral to medial, what am I looking for first? Iliocostalis. There are a couple different designations, so thoracis or lumborum, but these two are iliocostalis, longissimus, aptly named because it is quite long, spinalis in the middle. Let's maybe consider, let's think of longissimus first of all. Let's maybe consider what it does before we get into too much specific detail. What does longissimus do? Extension of the back. And hyperextension because it does cover or extend past the lumbar spine. All of these muscles do the same action. The caveat to that is that not all of them hyperextend. All of them extend, not all of them hyperextend. But I won't go into too much detail about that. So this is the main action of the erector spinae muscles, but they also contribute to lateral flexion. Seamless. Look at that. No stutter at all. How is it possible, if I turn on longissimus, that it can both extend and laterally flex? Same muscle being activated. Why do I have two very different actions? Yeah. Fantastic. What if I only turned on one side, the right erector spinae muscles, and deactivated the left side, lateral flexion? If I engage both, extension. Fantastic. Okay, so let's also use longissimus as our example for innervation and supply. Posterior ramus, there's a whole list, but in general, posterior rami. And let's take a look at what that looks like. So you can see here, highlighted in blue, all of the spinal rootlets that combine to make spinal roots, that make spinal nerves, and as they exit the vertebral column, they split to make anterior and posterior rami. So you can see the section at the front, sort of at the front right of the screen, that's chopped off. That would have been the anterior ramus. It's gone. You're not needed right now. The posterior ramus is what's shown here, piercing longissimus and innervating it, activating it. And so the posterior rami, all the way up the spine, have that job, are tasked with innervating longissimus. If you're curious, say, oh, he cherry-picked longissimus. Let's take a look at the nerves of spinalis. Same nerves. Posterior rami, we have a bit more dispersion superiorly because it extends a bit further up. Posterior rami, innervating muscles of the deep back. Notice they don't only do that, and you can see some of their terminal branches, which would be iliocostalis on the far side. But those rami innervate all the erector spinae muscles. What about arterial supply? This is a really nice diagram, and the reason that I introduced the costal grooves is for this purpose. These are the intercostal arteries. They travel with intercostal veins, and surprisingly, intercostal nerves. These travel in the costal grooves all the way along the border of the ribs, as you can see here, supplying not only the muscles of the deep back, but, for our purposes here, supplying iliocostalis, longissimus, and spinalis. So now we have a really nice sense of where that nervous supply comes from, where that arterial supply comes from, and the actions of these muscles. Anyone know what the big purple rectangle in the middle is? Big purple column? It's not important right now, but we'll get there. I got to leave you in suspense, right? Okay, I think that's all we need here. Let's take a look. What else do we have? Oh, there are a couple other ones. Not the erector spinae muscles. There are a class that don't connect vertically across the spine, across the vertebrae in the spine. Transversospinales. Transversospinales. Transverse across the spine. And I bring these up because one is important in lumbar support, which is something you may or may not have heard about or have trouble with or be conscious of now that I mentioned it, in securing good posture for yourself in your seat. And the other helps to rotate the spine. And it's a pretty unique action, so I think it's important to introduce. And you can probably guess which is which. Rotation of the spine, probably is the action of multifidus, right? No, of course not. Rotatores probably rotates the spine. So you can see multifidus down here, a really large, thick muscle, starting in the lumbar region. Actually, it goes all the way up the spine as well. And rotatores, we'll zoom in and take a quick look. But these generally connect the transverse process of a vertebra to the spinous process of the vertebra above it. So from the outside, moving in and up. That's what the rotatores do. Any guesses on the innervation of these deep back muscles? I know you know. Who else has an idea? What nerves would innervate these muscles? Who was paying attention in the last 5 minutes? Yeah, Olivia. The what, sorry?
The rami.
The rami. Which rami? Posterior rami, absolutely. Posterior rami of the spinal nerve. I like to think that you all knew that, but you just didn't want to single yourselves out, right? I get it. Posterior rami of the spinal nerves, absolutely. Innervate both of these muscles. Blood supply, lumbar and intercostal arteries. Very similar. You can see some parallels between the muscles that we've introduced here. So, entertain me. Let's take a look. Maybe entertain me isn't the right word. Humor me. Let's check out multifidus. Look at that. Multifidus. Long in its own right, but not made up of consistent long muscle fibers. You can see these all generally move superior and medially. Multifidus. Actions of multifidus, partly rotation, partly extension, partly lateral flexion, so it's kind of a jack of all trades. And multifidus, really, normally the muscle will highlight when it's contracting, but I really think this is backwards. Muscles only shorten when they contract, and so return to the midline would be contraction. I think the highlighting is off. Jack of all trades. Let's take a look at the nerves. Look very similar to what we just saw. Posterior rami, and these ones are right between the transverse processes and the spinous processes. That little hole in the vertebrae, the cup made by those processes, that's where multifidus sits. So you can see the deep branches piercing that muscle right away. And surprise, surprise, intercostal arteries, supplying muscles of the deep back. Also some lumbar arteries, which look a lot like intercostal arteries, but they're not between ribs, so they're not called intercostal. The rotatores are a little more detailed, a little more interesting. Let's get rid of multifidus. Rotato. Where are you? Hide. There we go. So you can see what I was trying to describe previously. These connect from the transverse processes of one vertebra to the spinous process over the vertebra above it. There are two kinds, and some do span the entire or two intervertebral spaces, but they both have a very similar action to draw the spinous process towards the transverse processes. And I won't go into depth about the nerves and the arterial supply. Same story we've heard all day. But you can imagine the action. Actually, why don't we just quickly look at the action. Now these are very small muscles. So even though, let's get rid of all. So you can see them hidden very deep within those deep back muscles, just highlighted barely upon rotation. They're very small, so they don't provide a lot of force. They don't do a lot of rotating themselves. They really monitor position of the spine and then send information back to the brain, which engages the larger movers, the larger rotators like multifidus, the supporting muscles of the deep back. These ones are mostly for proprioception, understanding the position of the spine in space. Very small, can't provide a lot of force. So we just saw the rotatores. You can see those here. Again, highlighting the difference between, or the span of the transverse to spinous processes. Posterior rami, intercostal arteries, no surprise on the supply and innervation. I thought it was worth introducing the scalene muscles. Scalenes are specifically in the cervical spine near the top of the vertebral column, where we run out of ribs. Right? The spine extends above the ribs, above the clavicles, above the shoulders, and the scalenes help to support and articulate and move the vertebral column in the absence of ribs. Everything that we've looked at so far articulates with the ribs and the vertebrae. These articulate between the most superior first and second ribs and the vertebrae above them. One small difference here. So far, we've only seen posterior rami, but we're disrupting the status quo. These are innervated by cervical nerves, cervical spinal nerves, which makes sense. Those nerves would arise from the spine, the cervical spine, where the scalene muscles reside, and innervation would be immediate in that general vicinity. While this is a disruption to the status quo, it's easy to remember because their supply are cervical arteries. Cervical nerve, cervical artery. The innervation and supply for these scalene muscle groups. I'm going to show you briefly, not in a lot of detail, but this 2D picture presents the scalenes and breaks them into three groups. So I've highlighted the middle scalenes as the exemplar, but there are posterior, and you can guess where that is, and anterior scalenes. But just to see them in space, in their respective orientations, all the scalene muscles are shown here, anterior, medial, and posterior. All of them innervated by cervical nerves, supplied by cervical arteries, and you can see they're set up here a bit more easily, I think, than in the diagram in the slides. So what would they do? Did we talk about what they did? What would you guess their actions were, the scalenes as a group? Some portions are more involved in certain actions than others, but what would you guess they do to the head? Let's say, what of the head? Yeah.
Hold it up.
Hold it up. Okay, so extension. Yeah. What else? Yeah.
Could it be like lateral movement?
Lateral movement. So what kind of lateral movement?
So they usually can use because
Okay, and we would call that.
adduction.
Okay, that's not a bad guess actually. Adduction toward the midline. I guess technically we're moving away from the midline. But it's in the right ballpark. The name that we use for this motion is lateral flexion, just to separate it out from normal flexion forward. Lateral flexion, extension. Anything else? What if you only activated one side? Yeah. Rotation. Good stuff. All the usual suspects. We've seen these already. Here we can apply them as well. So imagining how those actions would be executed by these muscles is something new that you've just translated, which is nice. Okay, let's talk about the muscles of the thorax that assist in breathing. You've had a lengthy discussion in lab about the mechanics of breathing. If you're in Thursday's lab, you'll get that today. To drive air in, it's really the passive suction of air that we're trying to accomplish. We do that by lifting the ribs, dropping the diaphragm, making the thoracic cavity bigger, which drops the pressure and draws air in. So in order to breathe, the muscles need to activate to make the thoracic cavity bigger. Of course, the main muscle, at least in passive breathing, that is involved in making the thoracic cavity bigger is the diaphragm. And we are not going in depth in class on the diaphragm, but I expect you to know that because you've all been in lab and you'll have a fantastic animated series of slides and lecture on how the diaphragm works. But we're going to focus briefly on the external and internal intercostals. The external intercostals are external, the most superficial intercostals. And where are they? Intercostal, between ribs. Internal intercostals are less superficial, but also between ribs. There's not a lot of time to discuss all of the mechanics, so I might just help you remember which is which. External, hands in pockets. Hands in pockets. External intercostals, fibers run in the direction of your fingers when you put your hands in your pockets. Pockets are usually external. Hands in pockets. Internal intercostals, you can think of them as being opposite to external, and in fact, the actions, the orientation, everything is opposite about internal intercostals. Hands in armpits. Or some other jazz hands maybe, I don't know. Hands in armpits. Fingers pointing up and up and lateral. Hands in armpits show the direction of the internal intercostals. Now I will just list these and we'll look at examples when we get back to class tomorrow. This is taking longer than I wanted, but I like the 3D manipulation of this information. Posterior rami. So really, posterior rami do a lot. That's not right. Intercostal nerves. This was an error in copy pasting. Intercostal nerves innervate the intercostals. Just like intercostal arteries supply the intercostals. Make sure you write that down because that's not correct as it's shown on the slide. Intercostal nerves and arteries supply the intercostals. All right, we're going to leave it there. We'll speed through the rest on Friday tomorrow and then get into the pectoral girdle, which sets the stage for our discussion of the shoulder, my favorite joint in the body. See you tomorrow.